today. And this should cover most of the content. Capillary malformations, also known as port wine stains, are the most common vascular malformation that we see in children, and these are present congenitally. We'll see these in infants presenting with red patches. You can see in the photos here on the left, there's a child who has a large capillary malformation with some associated soft tissue overgrowth, a baby with facial capillary malformation, and then another infant who has a more extensive block-type capillary malformation on the body. Nevus simplex complex is a transient birthmark which can mimic capillary malformation. These consist of midline vascular patches. They generally fade by age 2, and you can distinguish them from port wine stains or capillary malformations that are more lateral and tend to darken over time. Some of the classic locations for nevus simplex include the upper eyelids, the glabella, the nape of the neck, and the lumbar area, as seen in this photo. How do you manage extensive capillary malformations and port wine stains on the face? If the capillary malformation involves the upper or lower eyelid, it's important to get an eye exam to rule out glaucoma. Imaging with MRI is indicated if the baby has associated neurologic symptoms like seizures to assess for Sturge-Weber syndrome, or if there's associated bone or soft tissue overgrowth to assess for deeper vascular malformations. It's also important to refer to pediatric dermatology for consideration of possible laser treatments. Another entity to distinguish from port wine stain is a segmental infantile hemangioma. Sometimes it's a little difficult to distinguish an early hemangioma precursor from a port wine stain. And this can be difficult just in the first few weeks of life, but usually with time, what you'll notice is that hemangiomas become more elevated with texture changes and can proliferate. So on the left, you can see a large facial segmental hemangioma compared to a baby who has a capillary malformation port wine stain. So what are the clinical findings of Sturge-Weber syndrome? Sturge-Weber syndrome consists of a facial port wine stain, usually in a V1 distribution over the forehead, and it tends to be a larger facial stain. There's ocular involvement in 60% of the patients, with glaucoma being the most common finding. Leptomeningeal angiomatosis, when present, can present with seizures, and other neurological symptoms can develop like headaches, migraines, stroke-like episodes, and focal neurological defects. Some of these patients also have developmental delays, soft tissue overgrowth, particularly of the maxilla, and also this can be a stigmatizing condition. Here's a table to summarize the management of Sturge-Weber syndrome if you want to pause your video and review this slide. A 4-month-old female infant comes to your office with this growing lesion. Her mother reports it was not present at birth, but was noticeable at 2 weeks of age and is growing. It's more raised and more red. How would you manage this patient? A, start oral prednisone. B, refer to pediatric dermatology and ophthalmology. C, reassure the parents. This lesion will eventually involute. D, continue to monitor the growth monthly. Or E, start topical timolol. The answer is B, refer to pediatric dermatology and ophthalmology due to the concern of the hemangioma proliferating and potentially affecting the baby's vision. For your reference, here is a great article in Pediatrics that's a clinical practice guideline reviewing the management of infantile hemangiomas if you want to review this topic in more depth. The natural history of infantile hemangiomas starts out with a hemangioma precursor lesion. These may be present at birth, but sometimes are hardly noticeable. They can appear, like in the top right, as a blanched halo, small erythematous patches. There's then subsequent rapid growth of a superficial component in the first month of life. The superficial hemangiomas are bright red and minimally elevated. There's also a deep type of hemangioma, which can have a longer growth phase, but in general, the majority of growth of hemangiomas is complete by 4 to 6 months of age. Hemangioma growth then plateaus at about a year of age, followed by natural involution, where the endothelial cells are replaced by fat and fibrous cells. 90% of this involution happens by age 4. Hemangiomas, although they involute, may leave residual erythema or scarring, as you can see on the right with the hemangioma scar. It's important to recognize certain types of infantile hemangiomas and manage them appropriately. Ones to consider referring, and we prefer to see referrals early in the first 1 to 3 months of life so that treatment can be considered and hemangioma growth can be prevented. The high-risk lesions to consider referring are especially ones on the face, diaper area, and large hemangiomas. Hemangiomas greater than 5 centimeters on the face, as seen in the upper right, may be associated with a condition called face syndrome and require further workup. Hemangiomas overlying the lumbar spine may also need further workup for lumbar syndrome. And having multiple cutaneous hemangiomas greater than 5 usually requires an abdominal ultrasound to rule out intrahepatic hemangiomas. High-risk locations like the vulva and diaper area are also at risk for ulceration, and we recommend treatment for these hemangiomas. The main treatments that we do are oral propranolol or topical timolol, which can be useful for very small superficial hemangiomas, but is not useful for thicker ones. Observation for spontaneous resolution is also often done for small, uncomplicated hemangiomas, such as small ones on the trunk. Here are some examples of high-risk infantile hemangiomas involving the face and neck. Hemangiomas of the nose, upper eyelid, and ear are at risk of disfigurement or permanent distortion of these anatomic landmarks. Lip hemangiomas, neck hemangiomas are at increased risk of ulceration. The large facial segmental hemangiomas also have a high risk of scarring and a risk of an associated structural anomaly as seen in face syndrome. Segmental hemangiomas on the extremities also have a higher risk of ulceration, permanent skin changes such as thickening, atrophy, or scarring. 5 or more cutaneous hemangiomas at any anatomic site may be associated with hepatic hemangiomas. And perineal or perianal hemangiomas have an increased risk of ulceration. Small lesions at the torso are lower risk, less likely to be disfiguring, and typically do not require any active intervention. Segmental, lumbosacral, or perineal hemangiomas are at higher risk of ulceration and may be associated with underlying structural anomalies such as lumbar syndrome. Moving on to another type of newborn rash, transient neonatal pustular melanosis affects 5% of newborns with darkly pigmented skin. The rash begins with superficial pustules without erythema that rupture, leaving a colorative scale and hyperpigmentation that may last for several months. As you can see on the upper right, there's small pustules which then form a colorative scale and leave hyperpigmented macules as seen in the bottom photo. This rash favors the forehead, neck, back, and shins, but sometimes is widespread. When it presents with pustules, you'll also want to distinguish it from staph pustules, which can be done by a swab. Both transient neonatal pustular melanosis and staph will show neutrophils. However, staph will also show a positive Gram stain. Erythema toxicum neonatorum shows eosinophils on swabs, which helps you distinguish it from transient neonatal pustular melanosis, which has neutrophils. You can pause the talk to review this slide, which reviews the differences between erythema toxicum neonatorum and transient neonatal pustular melanosis. Neonatal impetigo is another newborn rash, which can present at 2 to 3 days of age to the second week of life. Usually, you'll notice superficial vesicles, pustules, or bulla on an erythematous base, and these blisters are easily denuded and can lead to red, raw skin. This rash favors the folds, so particularly axilla, neck folds, and diaper area, and is more commonly caused by Staph aureus than strep. A full-term healthy infant presents for a well baby exam. You notice bluish-gray patches along the infant's buttocks, lower back, and shoulders. No additional birthmarks are seen, so you make the diagnosis of A. Cafe au lait spots, B. Congenital melanocytic nevi, nevus of Oda, D. Dermal melanocytosis, or E. Phacomatosis pigmentovascularis. The correct answer is dermal melanocytosis. Cafe au lait spots would be brown oval patches. Congenital melanocytic nevi would be more elevated brown plaques or hyperpigmented plaques. Nevus of Oda can look similar but is located on the face. And phacomatosis pigmentovascularis is a syndrome that has extensive dermal melanocytosis but also associated vascular malformations such as capillary malformations. Dermal melanocytosis, as you know, is a congenital birthmark that is very common, affecting 80% of Black, Asian, and Hispanic infants and 10% of white infants. The lumbosacral location is most common, but this can happen on the scalp, gluteal region, shoulders, and extensor extremities. These generally fade by 2 to 3 years of age, but rarely extensive lesions can be associated with several syndromes, including phacomatosis pigmentovascularis, Hunter and Hurler syndrome, and some of the gangliosydoses. There are many different etiologies of diaper dermatitis. Some of the common causes include an irritant contact dermatitis, which is the most common diaper dermatitis that you'll see. This favors the convex surfaces and spares the folds. We usually treat this with barrier creams or hydrocortisone. Candidiasis favors the folds and can be associated with satellite pustules, as you can see surrounding the vulva in this baby. This is treated with topical anti-yeast medications such as nystatin or ketoconazole cream. Seborrheic dermatitis favors the folds. You'll always or usually also see involvement of other flexural surfaces like the axilla and also involvement of the scalp. Babies often have cradle cap plus the diaper rash. And this can be treated with hydrocortisone and ketoconazole. Less common causes of diaper dermatitis include bacterial infections like bullous impetigo. With bullous impetigo, you'll see flaccid bulla as pictured on the right. With perianal strep, there's a very well-demarcated bright red erythema of the perianal skin. With psoriasis, you'll see well-demarcated plaques. Sometimes this can appear a little bit more shiny in the folds, and more of the silvery scale that's classic for psoriasis will be visible on the convex surfaces. The babies may have psoriasis elsewhere, although often psoriasis in infants can present first in the diaper area because it's a high friction area, and there may be a positive family history of psoriasis. Allergic contact dermatitis is something to consider if the rash fails to respond to treatments, and we sometimes see this from allergies to diaper wipes or to the diaper itself. The most common location for contact dermatitis to the diaper is actually along the hip and buttock area, and this can be from allergies to things like rubber accelerators or dyes in the diaper. Some rare causes of diaper dermatitis to consider are acrodermis enteropathica, zinc deficiency, which presents with more eroded orangey red plaques. Infants may also have associated facial rashes and acral dermatitis on the hands and feet. With Langerhans cell histiocytosis, you'll often see crusted and eroded papules in folds, such as an inguinal fold. With early Kawasaki disease, one of the Kawasaki rashes that we commonly see is in the diaper area and presents with erythema and desquamation. Moving on to inflammatory skin disorders. To make the diagnosis of atopic dermatitis, patients must have at least 3 basic clinical features, including pruritus, a typical morphology and distribution of the rash, chronic or chronic relapsing course, or a personal family history of atopy. There are also multiple minor clinical features of atopic dermatitis. On the top right, you'll see fine white scales on the legs that are consistent with ichthyosis vulgaris. On the cheeks and upper arm of this other patient, you'll see these follicular hyperkeratotic papules that are consistent with keratosis pilaris. Patients with atopic dermatitis often have an early age of onset of the rash, associated dry skin, lip dermatitis, hand eczema, lichenification, elevated IgE levels, itch with sweating, recurrent infections, pityriasis alba, which we'll discuss further in a moment, dermatographism, and some eye symptoms. Pityriasis alba can be seen on its own, but is also a minor clinical feature of atopic dermatitis that you may see in patients with eczema. These are asymptomatic hypopigmented patches, most commonly located on the cheeks, and most frequently noticed at the end of the summer after significant sun exposure. Also more common in darker skin types. Treatment is with moisturizers and very good sun protection, and families can be reassured that the skin will repigment and skin tone will return to normal, but it may take several months. For severe cases, this can also be treated with a mild topical steroid or calcineurin inhibitor. Some examples of typical atopic dermatitis in a child less than 2 years of age. You can see the classic facial dermatitis with erythema and scaling on the cheeks, and then the extensor surface involvement of the toddler with extensive lichenification and hyperpigmentation. After age 2, the eczema tends to become more flexural, and you can see the flexural dermatitis here involving the antecubital fossa and the popliteal fossa with ill-defined erythematous papules coalescing into plaques with excoriation, scaling, fissuring, and weeping. Diagnosing atopic dermatitis in black skin is important to know about. Sometimes the erythema that's visible in lighter skin types is harder to see, and so you may see a lot of follicular, papular, and nummular morphology with multiple circular lesions, very significant lichenification, and a lot of hyperpigmentation and dyspigmentation. Managing atopic dermatitis consists of 4 key factors. The mainstay of treatment is gentle skin care. Treatments are directed at controlling inflammation with topical medications. Treating infection, if present, is important, and antihistamines are sometimes used for itching. Topical steroids are the mainstay of treatment for atopic dermatitis. We want to choose the least strong topical corticosteroid that will do the job. Generally, ointments are going to be more effective for chronic eczema, and most kids don't mind the lack of cosmetic elegance from the greasy ointments. For example, using hydrocortisone 2.5% ointment for the face and triamcinolone 0.025 to 0.1% ointment for the body. There may be situations where you would consider a non-steroidal treatment. This is not currently first line, and the options include topical tacrolimus, pimecrolimus, and crisaborole. Crisaborole is FDA approved for 3 months and up. Tacrolimus and pimecrolimus are approved for age 2 and up. These can be very useful medicines for certain sites like the face, periocular areas, intertriginous areas as a steroid-sparing agent, and also are useful for recalcitrant disease. I also find these medicines useful for maintenance therapy. After the eczema flares are cooled down with a topical steroid, you can then switch to a non-steroid medicine on the eczema hotspots for maintenance. There are many newer treatments in the pipeline for pediatric atopic dermatitis. Some of these are now approved, including dupilumab, which is FDA approved for 6 years and up for atopic dermatitis. There are other monoclonal antibodies being studied as eczema treatments, as well as JAK inhibitors and PDE4 inhibitors. One of the most common complications of atopic dermatitis are secondary infections, especially with Staph aureus. Up to 90% of patients have affected skin that's colonized with staph, and this can lead to impetigo and rarely sepsis. Strep is less common in patients with eczema, but can happen. Other infections that we frequently see include herpes simplex virus, which can cause eczema herpeticum, Coxsackie virus A16, which can lead to eczema coxsackium, and molluscum contagiosum frequently causes secondary infections in patients with eczema. Impetigo is a common complication of eczema. With secondarily infected eczema, you'll see this honey yellow crusting, and in this baby, you can see this around the mouth on top of her eczema. My approach is usually to do swabs when flares occur. Look for pustules. They are often scratched off by the patient. If there's heavy growth of staph on cultures, we'll consider treatment with oral antibiotics. However, most of the time we try to manage staph superinfection with topical treatments like diluted bleach baths. This has been shown to reduce the amount of systemic antibiotics that are needed and can be performed by diluting a 1/4 cup of bleach in a half adult bath, having the patient soak in the bath for 10 minutes at a time, and do this procedure 2 to 3 times per week. This can help both the eczema as well as prevent secondary infection. Other potential complications of atopic dermatitis that we see include comorbidities with other atopic diseases. Sleep disturbance can be severe, and there are also psychiatric comorbidities, anxiety, conduct disorder, and depression in patients with eczema, which is one of the reasons why it is important to treat these patients. Here's a proposed treatment model from Pediatrics in Review. The basic management is skincare with moisturizers and warm baths, antiseptic measures such as dilute bleach baths, and trigger avoidance, avoiding common irritants. For acute treatment, we then use low-potency topical steroids twice daily for up to 3 days beyond clearance. For more moderate to severe disease, you may want to add a maintenance topical calcineurin inhibitor or a maintenance topical corticosteroid that you do on the eczema hotspots on the weekends. For a relapsing course, you'll apply the topical anti-inflammatory medication at first signs of symptoms to the flare-prone areas. For acute treatment, you'll apply the topical anti-inflammatory medications to the inflamed skin, usually a more medium potency medication, and you also want to consider secondary infection that might require antibiotics. If the flare isn't resolved within 7 days, consider non-adherence to the treatment plan, infection, misdiagnosis, and consider referral to dermatology. Allergic contact dermatitis is a subset of eczema, and one of the most common types of allergic contact dermatitis that we see in children is the Rhus dermatitis, which is from the urushiol oil in plants such as poison ivy or poison oak. This frequently gives you linear blisters, which are signs of an outside job. You'll often see linear and geometric shapes of the rash, and it's also usually intensely itchy, can cause blisters or an eczematous and spreading rash. Some other common causes of contact dermatitis that we see in children include nickel allergy, allergies to preservatives and personal care products, or topical antibiotic allergies like neomycin and bacitracin. For hypopigmentation in children, there's a broad differential diagnosis. This includes vitiligo, pityriasis alba, post-inflammatory hypopigmentation, which is probably the most common cause of hypopigmentation that we see in children, hypopigmented tinea versicolor, certain birthmarks, and some rare diseases including some infections, and cutaneous T-cell lymphoma. The most common type of cutaneous T-cell lymphoma in children is hypopigmented mycosis fungoides. The distinguishing feature of vitiligo is that you'll see depigmented patches. These are often symmetric, asymptomatic, they're flat, there's no scale. There's a variant of unilateral vitiligo called segmental vitiligo that can be seen in 15 to 30% of children. Vitiligo also frequently capnorizes, so it appears in areas of friction and trauma, such as the knees, elbows, and ankles, and hands. There's significant stigma and impact on quality of life, which is why we feel that treatment should be offered for patients with vitiligo. An example of depigmented symmetric patches on the bilateral knees. When repigmentation begins in vitiligo, what you'll see is follicular repigmentation with small brown macules occurring within the depigmented patches, and this is from melanocytes migrating up through the hair follicles. How to evaluate a child with hyperpigmentation. Approaching disorders of hyperpigmentation, one approach is to look at the location of the hyperpigmentation and see whether it's circumscribed, diffuse, linear, reticulated. Here is a list of some of the disorders of hyperpigmentation. This is our main differential diagnosis of hyperpigmentation in children. You can see it's quite extensive. This includes birthmarks and growths such as nevi, freckles and lentigines, caffeole spots, dermal melanocytosis, and mastocytosis. There's also inflammatory skin disorders that can lead to hyperpigmentation, such as erythema chromicum perstans, also known as ashy dermatosis, lichen planus, and post-inflammatory hyperpigmentation. Post-inflammatory hyperpigmentation is the most common type of hyperpigmentation that we see in children, especially from inflammatory skin diseases like atopic dermatitis, acne, after viral exanthems, after transient neonatal pustular melanosis. You can see the photo here on the right showing post-inflammatory hyperpigmentation from psoriasis on the elbow. Some more rare causes of hyperpigmentation include metabolic causes, heavy metals such as excess sulfur ingestion, or drug-induced hyperpigmentation. Some other specific examples of hyperpigmentation to review include the hyperpigmentation associated with incontinentia pigmenti. This is the third stage of incontinentia pigmenti, which occurs within the first year of life with gray-brown streaks along the lines of Blaschko. These lines then gradually fade during late childhood. Linear types of hyperpigmentation are usually genetic in cause and may require further workup. A 12-year-old boy presents with his mother for evaluation of a mole that appeared several months ago in his back. It's been asymptomatic and is stable in size. On examination, you notice an 8mm brown macule. Which of the following features of this mole is concerning for melanoma? Is it A, symmetry, B, border, C, color, D, diameter, or E, evolution? The correct answer is diameter, more than 5mm in size. Although this mole to me looks clinically benign, technically that is one of the ABCDE criteria for melanoma. Another example to review is the hyperpigmentation associated with urticaria pigmentosa. Urticaria pigmentosa is also a subset of mastocytosis that's also called maculopapular mastocytosis. And children present with hyperpigmented macules. When these are scratched, there's a positive Derier sign and they urticate and become hives. Note the hyperpigmented macules here on the trunk. I'm going to review some of the clinical features associated with ichthyosis. There are many different types of ichthyosis, with phenotypes ranging from mild to severe. What they have in common are fish-like scales. One of the most severe types is the autosomal recessive congenital ichthyoses. These patients present with large plate-like scales. They're often born with collodion membranes and have ectropion and eclabion, where their eyes and lips are distorted from having the tight scaling on the face. X-linked ichthyosis affects boys. There's sparing of the flexural areas. As you can see in this photo, the antecubital fossa is spared, and they're surrounding hyperpigmented fish-like scales. Ichthyosis vulgaris is autosomal dominant. It's the most common type of ichthyosis that we see. It's also the mildest type, and this presents with scaling on the legs, can be associated with hyperlinear palms, and there's a very strong association with atopic dermatitis because patients with ichthyosis vulgaris and atopic dermatitis have a filaggrin mutation. Syndromic ichthyosis is associated with certain metabolic disorders, and these are quite rare. There is genetic testing available to distinguish the different types of ichthyoses. Usually when a baby is born with a collodion membrane, we'll order genetic testing to assess the type of ichthyosis. The general management will be with frequent application of emollients and involving pediatric dermatology in the care of these patients. Other treatments we sometimes do include topical and oral retinoids, and then treating complications such as pruritus and secondary infections. The main clinical features associated with psoriasis are well-demarcated erythematous plaques with silvery scale. These are often located on elbows, knees, and scalp. There's another type of psoriasis called guttate psoriasis, where you'll see multiple raindrop papules, and this sometimes is triggered by strep throat or upper respiratory infections. Nail pitting and thickened nails can be associated with psoriasis. Patients may also have a subtype called inverse psoriasis, which affects the axilla, the groin, and the gluteal cleft. About 10% of children with moderate to severe psoriasis have joint involvement, and so some patients may have associated psoriatic arthritis. Pediatric patients with psoriasis also have comorbidities such as obesity and metabolic syndrome that may require further screening. Another papulosquamous disorder is pityriasis rosea. Classically, this presents with a herald patch, which is a larger initial patch or plaque. Subsequently, multiple oval pink plaques with a colorative scale form in a Christmas tree distribution, usually along the trunk. This rash lasts 4 to 6 weeks, but sometimes up to 3 months. For mild cases, no treatment is needed, but this can be treated symptomatically with antihistamines and topical steroids. Generally, we'll observe for spontaneous resolution. It's important to note that secondary syphilis can sometimes mimic pityriasis rosea, so something to consider in your older patients. Acne vulgaris is an extremely common disorder that we see in the majority of teenagers, but this can affect infants and also happen into middle life. For mid-child acne, ages 2 to 7, these patients do require a systemic workup. It's not normal to have acne between ages 2 and 7, and so you'd want to rule out an endocrine abnormality or precocious puberty. Acne is also a significant cause of psychosocial morbidity and is associated with depression, which is one of the reasons that we treat acne. We also want to treat acne to prevent permanent scarring. Acne most commonly affects the face, chest, upper back, and shoulders. Comedonal acne is how early acne presents and can appear as early as 8 years of age with the onset of puberty, usually in the forehead and T-zone area with open and closed comedones as shown here. Inflammatory acne consists of erythematous papules and pustules. This can cause significant hyperpigmentation and darker skin types. Nodular cystic acne is the most severe type of acne. The nodules will be firm on palpation and cysts will be more fluid-filled, and this is an indication to start isotretinoin. I still refer to these evidence-based recommendations for the diagnosis and treatment of pediatric acne that have been published in Pediatrics. First-line therapy for mild acne is with topical therapy. As dermatologists, we like to include retinoids in all of our acne regimens, and generally we're going to start out using a milder retinoid like tretinoin 0.025% cream or adapalene gel or cream. The main side effects of retinoids are skin irritation, dryness, and photosensitivity. This can be managed with moisturizers and sun protection. In terms of antibiotic stewardship, we prefer using combined antibiotics that are combined with benzoyl peroxide. Other agents that are used are topical dapsone, azelaic acid, salicylic acid, and sulfur washes. For moderate to severe inflammatory acne, other treatments that can be done include oral antibiotics, usually doxycycline or minocycline. For women and girls, we consider hormonal agents like spironolactone, and there are several FDA-approved oral contraceptives for the treatment of acne, especially Yaz, orthotricycline, and estrostep. A combination treatment with a topical retinoid and antimicrobial agent such as benzoyl peroxide or benzoyl peroxide wash is the preferred approach for almost all patients with acne. The use of topical or oral antibiotics should be combined with benzoyl peroxide or retinoid to limit the incidence of antibiotic resistance. Oral isotretinoin is the most effective medication for acne. This is usually a treatment that we go to when other treatments have failed or when the patient has scarring or nodular cystic acne. Moving on to cutaneous infections. Impetigo is caused by strep, staph, or both. It's most common in infants and young children. And with impetigo, you want to look for eroded bulla or flaccid blisters. There are two main types. There's bullous impetigo and there's non-bullous impetigo. The non-bullous impetigo will present with more honey crusts. Historically, non-bullous impetigo was caused by strep, but nowadays most of these are caused by staph. Bullous impetigo is also common in the diaper area. It's the same exfoliative toxin that causes staph scalded skin syndrome. Topical antibiotics can be used to treat mild disease, but for severe disease we use oral antibiotics or systemic antibiotics. A 3-week-old infant with a history of neonatal seizures being treated with phenobarbital presents to the ER with a 1-day history of diffusely distributed bright red patches and several superficial bulla. The Nikolsky sign is positive. On further exam, you note the mucous membrane of the mouth, tongue, and conjunctiva are spared. What is the cause of this rash? Is it A, Staph aureus, B, Kawasaki disease, C, drug hypersensitivity reaction, D, group A strep, or E, measles? This is caused by Staph aureus, resulting in staph scalded skin syndrome. Note the perioral fissuring here and the erosions and erythroderma that this baby has. Staph scalded skin syndrome is caused by an exfoliative toxin producing strains of Staph aureus. Infants will present with diffuse erythema and superficial blisters and the classic perioral fissures and crusting. It's more common in young infants or in children that have immature or poor renal function, which is one of the reasons why they have more difficulty excreting the toxin. It's important to know that blisters will be negative when you swab them, so we usually swab all of the orifices, including the eyes, the nose, and perianal skin. Nikolsky sign is positive in staph scalded skin syndrome. This is when you apply tangential pressure on the blister and it causes extension of the blister. This condition is usually treated as inpatient with systemic antibiotics. Cellulitis of the skin is usually unilateral and presents with dermal erythema, edema, pain, fever, and swelling. We usually treat this with antibiotics to cover group A beta hemolytic strep and Staph aureus. Necrotizing fasciitis can initially mimic cellulitis early on. However, the intense pain out of proportion to clinical exam and then rapid progression with necrosis, as seen in this photo, or blistering, and lack of response to antibiotic is a major clue. Treatment is with prompt surgical debridement, appropriate antibiotics based on cultures. A 12-year-old boy presents with a pink annular scaly plaque on the shoulder. He has a pet rat that he likes to cuddle with. What's the most appropriate treatment? Is it A, nystatin cream, B, triamcinolone cream, C, mupirocin cream, D, terbinafine cream, or E, clotrimazole betamethasone cream? The correct answer is D, terbinafine cream, a topical antifungal to treat dermatophyte infection. Rats are a common source of this infection. It's also important to differentiate findings of tinea corporis from eczema and granuloma annulare. So tinea corporis is an annular plaque that has central clearing. It's caused by a dermatophyte fungus, and usually you'll see peripheral scale, as seen in the photo here. Whereas with nummular eczema, this is a type of circular eczema. It usually lacks the central clearing, and it's usually more itchy and more scaly and dry in appearance. Granuloma annulare, the lesions for granuloma annulare are dermal, so there's no scale that's seen. Usually they're small erythematous papules that coalesce into a circular plaque, and these are often located on the hands and feet. Going through some of the different types of tinea. For tinea pedis, athlete's foot, this is the most common fungal infection seen in developed countries, most commonly caused by Trichophyton rubrum. The fungus thrives in warm, moist environment. Good foot hygiene may prevent recurrences. There's 3 main patterns of infection that you may see: the interdigital pattern in between the toes, moccasin, and vesiculobullous. Moccasin tends to involve the entire sole of the foot. Interdigital is the most common that we'll see with scaling in between the toes. You also want to distinguish the clinical features of tinea pedis from atopic dermatitis. Atopic dermatitis typically involves the dorsal foot and is very itchy, whereas tinea pedis usually involves the skin in between the toes. Atopic dermatitis does not involve the fissures in between the toes. There is an eczema variant called juvenile plantar dermatitis that can involve the plantar foot. Usually you'll see very dry skin with fissures on the plantar surface of the entire foot. The main treatments for tinea pedis and tinea corporis include good hygiene and then antifungal creams. Usually we'll start off with topicals with imidazoles. Second-line treatment includes topical terbinafine or topical cyclopirox. For a very extensive disease, we'll also consider an oral antifungal. The clinical features of pityriasis versicolor or tinea versicolor. This is a colonization caused by a species of Malassezia yeast that's a normal resident on the skin. It tends to recur in the summer. It's more common in adolescents, and you'll see well-demarcated tan, salmon, or hyperpigmented patches on the trunk. Visible scale isn't usually present, but when rubbed with a finger or a scalpel blade, you'll see some scale that is readily seen. Looking more closely at tinea versicolor here, you can see some very faint browny scale over top of these hyperpigmented patches. Some more examples of tinea versicolor. This is usually located on the trunk. In darker skin types, you might see light macules. In some patients, you'll see dark macules. In light skin patients, more pink or tan macules. Treatment for tinea versicolor can be with shampoos, such as ketoconazole shampoo, applied daily to the affected areas and then rinsed off. This can be repeated daily for 1 to 4 weeks until the rash clears. It can be as effective as oral therapy. Another option is to do topical creams twice daily for 1 to 4 weeks. This can be very effective for limited areas, but can be a little bit more expensive than the shampoo. Tinea capis is another fungal infection to diagnose and manage appropriately. As you know, this is a dermatophyte infection of the scalp. Most commonly affects kids that are aged 2 to 7, and patients will present with patchy alopecia and scaling, as you can see here. There's also a variant with small black dots. Treatment of tinea capitis is with oral antifungals. It's really important to use oral antifungals because topicals do not penetrate the hair follicle. So the main options are griseofulvin, dosed at 20 to 25 milligrams per kilogram per day, or terbinafine. Terbinafine may be more effective for Tetons Reds infections. We often use a concomitant shampoo like ketoconazole, which can aid in removing scales and also decreasing reinfection. It's important that children receiving treatment should be allowed to attend school. A 6-year-old girl presents with an edematous, tender, boggy alopecic plaque on the scalp with several associated pustules. What is the etiology of this lesion? Is it A, inflammatory tinea capitis, B, Staph aureus, C, lupus, D, seborrheic dermatitis, or E, alopecia areata? The correct answer is that this is inflammatory tinea capitis that's led to a carrion. Carrion can be treated with prednisone, and we sometimes treat a secondary infection with antibiotics. Molluscum contagiosum is another very common infection that we see in children. The classic morphology of the lesion is going to be the central umbilication with these domed monomorphic skin-colored papules. Some will have indentations that look umbilicated, and some will just have small white cores visible. As you know, molluscum is caused by a pox virus. It affects younger patients, spread through water and skin-to-skin contact. It generally will resolve in 6 months up to 2 years. However, for some patients can be very symptomatic and can also be more severe in immunocompromised patients. Some of the other clinical features of molluscum, again, are the pink to skin-colored, flat, dome-shaped, smooth papules. Often they have central umbilication, sometimes just white cores. They're often in a linear array from capnorization. And then in the center, you can see a patient who has surrounding eczema or molluscum dermatitis. The molluscum often become inflamed or look infected before resolution, which we call the boat sign or the beginning of the end. When you swab these lesions, even though they look pustular, the cultures are usually negative. Molluscum contagiosum can be treated with observation, watchful waiting. In-office treatments that we commonly do include cantharidin for children. Cryotherapy is painful and we try to avoid it in children. Curettage can also be done. Topical creams such as tretinoin cream and Zymoderm can also be used. A 4-year-old girl presents to the clinic with several months duration of verrucous papules on the dorsal fingers. She attends daycare and other children have similar lesions. The most appropriate treatment for this condition is A, liquid nitrogen, B, cantharidin, C, salicylic acid, D, candida antigen injections, or E, imiquimod cream. Salicylic acid would be the most appropriate treatment for a wart in a 4-year-old, as we prefer to avoid any painful treatments. Imiquimod is FDA approved to treat genital warts, but generally not very effective for verruca vulgaris. Reviewing some of the treatment options for verruca. For younger patients, it's also appropriate to do watchful waiting. The most common treatment that we do is with topical salicylic acid. You can also use duct tape over top of the salicylic acid. Cryotherapy is our mainstay of treatment for older kids with warts. For recalcitrant cases, we'll use Effudex cream, which is topical 5-fluorouracil combined with salicylic acid. It's important to review the risks of these treatments as they also have risks of scarring, dyspigmentation, and may require more than one treatment. Immunotherapy can also be done for warts, most commonly with intralesional candida antigen. The HPV vaccine may have some cross-reactivity, so I always encourage teenagers to get the HPV vaccine if they haven't been vaccinated. And immunotherapy can treat distant lesions not directly treated, so this can be helpful when the patient has 10 or 20 warts because we'll treat only 2 warts, but the patient may have a systemic immune response that clears the rest of their warts. Again, we have to counsel the patients that there's a need for regular therapy and repeat appointments, and also may have risks of other side effects like hypersensitivity reactions. In this photo here, you can see condyloma acuminata with multiple verrucous papules surrounding the perianal skin. So condyloma acuminata affects the anogenital tract. It's mostly perianal, but also can affect the penis, scrotum, and vulva. The most common types are HPV 6 and 11, which are low risk, but patients sometimes also have high risk types of HPV. And this can be challenging because of the concern of transmission. A really detailed history and physical is important to establish whether this could be vertical transmission, a benign non-sexual heteroinoculation, auto-inoculation, for example, if the child has warts on the fingers, or could this be sexual abuse? So I usually obtain a detailed history about the age of onset, the maternal genital infection history, positive Pap test that the mother may have, the caregivers and close contacts wart history. And at times you may need to enlist help of a child protective agency. Depending on the HPV subtypes, you may also need to screen for cervical and anal cancers. Treatment of condyloma acuminata. One approach, like for all warts, is non-intervention. Another treatment that can be done is with imiquimod 5% cream applied 3 times weekly. Pedophylotoxin is another treatment for genital warts. And for very large or recalcitrant warts, you can consider surgical and laser treatments. Moving on to infestations. With lice, the eggs will hatch in 6 to 9 days, and these are usually located within 4 to 6 millimeters of the scalp. Nymphs are smaller than the adult louse, and it takes about 7 days to mature. They then develop into an adult who can lay up to 10 eggs per day. It takes about 12 to 14 days for the eggs to become adults, and then this cycle repeats itself every 3 weeks. Here's some examples of nits, these small white dots on the scalp, as well as an example of an adult louse. There is a high rate of permethrin resistance in the US and in California, so other treatment options besides permethrin include benzyl alcohol, which can be used for children older than 6 months of age. Malathion can also be used for children 2 years or older. If the child is too young or parents do not want to use a pediculicide, you can use manual removal of lice and nits with wet combing or occlusive method and repeat this for 3 weekly cycles. The spinosad and ivermectin are some other newer medicines that might be helpful in difficult cases of lice. Here's a chart to review of some of the topical pediculicides that are available for the treatment of head lice. Some of these may be very expensive, and based on my recent search, the 2 least expensive ones were malathion and spinosad. Pediculosis pubis is the pubic lice, and this can affect hair-bearing areas. Sometimes in children, this can also affect eyelashes. Other clinical features are the macula cerulae, which are bluish-gray macules on the chest and thighs, can be a sign of heavy infestation. Treatment can be done with shaving the affected areas using topical pediculicides, and for eyelashes, you can actually use ophthalmic-grade petroleum jelly. Papular urticaria is caused by insect bite reactions. These are very, very itchy, and patients can develop a generalized rash just after a few bites. And this can be a recurrent or chronic papular eruption that's caused by hypersensitivity to bites, especially from mosquitoes, fleas, bedbugs, and mites. This reaction can last from weeks to months, and then a new bite can kind of reactivate old lesions like lighting up a Christmas tree. And this most frequently is seen in children between the ages of 2 and 10. It can also be frustrating because usually there's only one child that's affected in the family. And so it can be a little bit challenging to convince the parents that the lesions are a bite reaction. And then also a lot of work to try to identify and eradicate the source of insects. You can manage papular urticaria with spot treatment with medium potency topical corticosteroids for itching. In the photo here, this is papular urticaria from mosquito bites on the legs of a child. Sometimes anti-itch creams with menthol, camphor, and pramoxine can also be helpful, as well as oral antihistamines. It's important to use protective clothing and insect repellents to prevent these recurrent bites. Scabies is a common skin infection that we see caused by the Sarcoptes scabii mite. Patients present with a very intensely itchy rash due to hypersensitivity reaction to the mite. Infants could present with irritability and poor feeding. Classic features would be to find burrows, linear burrows on the hands, wrists, and fingers. Papules that are present on the axilla, on the penis, and on the waistline are also very suspicious for scabies. Since infants aren't able to scratch off the mite, they more commonly will develop scabies nodules and sometimes will have their scalp involved with scabies. To confirm the diagnosis, we usually perform a scraping with mineral oil to identify the mite, and sometimes you can also see eggs or feces under the microscope. Treatment of scabies is permethrin cream, 5%, which is FDA approved for infants 2 months and up. You'll want to apply it from the neck down. It's left on for 8 to 14 hours and then rinsed off. You can also apply permethrin to the scalp and face. And then the treatment is repeated in 1 week time. It's very important to treat all the family members and close contacts to prevent reinfection, and then at the same time, wash all of the linens and clothing in hot water. The itching, because of the hypersensitivity reaction, can persist for several weeks. So usually I'll manage the pruritus with topical steroids, moisturizers, and antihistamines. Going through some of the different causes of hair loss in children, the 7-year-old boy presents with no significant past medical history. He presents with a 2-month history of hair loss. On exam, you notice several well-circumscribed, smooth, non-scarring patches of hair loss on his scalp. Which of the following is the most likely diagnosis? Is it A, telogen effluvium, B, anagen effluvium, C, trichotillomania, D, androgenetic alopecia, or E, alopecia areata? This non-scarring patchy alopecia is consistent with alopecia areata. Alopecia areata is a common type of non-scarring hair loss in children. It's considered to be autoimmune. Most commonly, it will present with the rapid appearance of smooth, bald, round patches. Usually these are asymptomatic. Sometimes you can see black dots, which represent hairs broken off at the surface of the scalp, or exclamation hairs. Here's some examples of black dot hairs in a patient with ophiacis pattern alopecia, which is behind the ears and along the occipital scalp. The ophiacis pattern along the parietal and occipital scalp can be more difficult to treat with a worse prognosis. If the entire scalp is involved, this is called alopecia totalis, and if both scalp and body hair is involved, this is alopecia universalis. Here's an example of alopecia universalis. There are many different treatment options for alopecia areata. In mild cases, you can observe for spontaneous regrowth, but usually these patients are referred to dermatology. We'll do treatments like high-potency topical steroids. Intralesional steroid injections can be done in teenagers. We'll also do topical minoxidil, topical immunomodulators, and JAK inhibitors are a very promising class of medications for the treatment of alopecia areata. In terms of differential diagnosis of non-scarring causes of hair loss, besides alopecia areata, you want to consider tinea capitis. Usually there'll be hair loss, but also more scaling, erythema, and associated lymphadenopathy with tinea capitis. Hair pulling or trichotillomania is a type of non-scarring hair loss, but usually you'll note irregular and geometric shaped patches with multiple broken off hairs of different lengths. Telogen effluvium is going to be more of a diffuse type of hair loss due to increased hair shedding, and this often happens months after illnesses, new medications, or surgeries, or different stressors. Here are some of the clinical features associated with hair pulling or trichotillomania. This is most common in adults, but when it occurs in preschool children, it has a good prognosis actually in younger children because it's more of a habit in a young child that they grow out of. The scalp is the most common site, but you can also see involvement of eyebrows, eyelashes, and sometimes pubic hair. The patient tends to have a habit of plucking, twirling, and rubbing the hair-bearing areas, which results in the hair removal or broken hair shafts. Sometimes this is done in bed, or the parents may not witness the behavior. And this is now considered to be an obsessive compulsive disorder. You can see in the photos here that the hairs are of multiple different lengths, as opposed to alopecia areata, where the scalp would be completely bald, and that the shapes are also irregular and geometric. Here's a child who has plucked their eyebrows and eyelashes, and again, the irregular shape of alopecia on the scalp. Referral to psych can be helpful for these patients. Telogen effluvium is caused by increased shedding of otherwise normal telogen hairs, and often in response to an illness like having had a high fever. There's also many medications that may cause this. The pandemic has caused a lot of telogen effluvium from all of the stress that everyone's been under. And there's also a neonatal form that we see around 4 months of age, which is physiologic and usually starts out along the occipital scalp. Clinically, you'll notice diffuse thinning of hair throughout the scalp. Patients may tell you their ponytail is smaller than usual. They could have a positive hair pull test. Usually for further workup, we'll do some basic labs just to check for thyroid and chemistry panels and markers of inflammation and iron status. Ferritin should be at least 40 to promote regrowth of the hair, and generally we provide reassurance that the hair will regrow. But for more recalcitrant cases, you can consider referral to dermatology. Going through dermatologic manifestations of neurocutaneous syndromes and genetic skin disorders, the main cutaneous features associated with neurofibromatosis in patients of various ages are cafe au lait macules, having 6 or more, axillary and inguinal freckling, plexiform neurofibromas, and cutaneous neurofibromas. One of the diagnostic criteria for neurofibromatosis is having 6 or more cafe au lait macules. This is the hallmark lesion that's present in 100% of patients with NF1. These usually will present very early in the first year of life and then increase in size and number in the first decade. The size is dependent on age, so if they're prepubertal children, the size will be more than 5 millimeters of these oval brown macules. In post-pubertal children, you'll see 15 millimeter brown oval patches. Axillary or inguinal freckling is another diagnostic criteria which presents with multiple hyperpigmented macules, usually 2 to 3 millimeters in size, that involve the axilla and groin. These commonly appear between 3 to 5 years of age, and 90% of children with NF1 have freckling by age 7. Neurofibromas are these soft, pedunculated papules and nodules, and having 2 or more of these is a diagnostic criteria, or having 1 plexiform neurofibroma. It's important to palpate large cafe au lait macules, especially with hypertrichosis, because some of these can have an underlying plexiform neurofibroma. The plexiform neurofibromas appear in late childhood and adolescence, or during puberty, or as adults. For your reference, here is the NIH diagnostic criteria for neurofibromatosis type 1. What test is most likely to be abnormal in this 1-month-old infant? A, liver ultrasound, B, eye exam, C, renal ultrasound, D, echocardiogram, or E, none of the above? The correct answer is D, echocardiogram. These are the Ashleaf spots of tuberous sclerosis. In this study, the most common presenting signs of tuberous sclerosis in infants were cardiac rhabdomyomas, followed by hypomelanotic macules. The development of cutaneous features in tuberous sclerosis happens at different times. The hypomelanotic macules are usually congenital. Facial angiofibromas become more frequent in the first years of life and are common in teenagers. Shagreen patches and periangular fibromas tend to happen in older teens and adults. The hypomelanotic macules, or Ashleaf spots, are generally more than 3 to 5 millimeters in size and fairly oval in shape. Facial angiofibromas having 3 or more on the face, or a fibrous cephalic plaque, which you can see the skin-colored plaque on the forehead. The connective tissue nevus, or shagreen patch, is this dermal skin-colored plaque. And then the periungual fibromas, somewhat verrucous lesions around the nail folds. And another minor feature that can be seen with cutaneous finding of tuberous sclerosis are the confetti skin lesions with tiny hypopigmented macules. A 2-month-old girl has vesicles and verrucous papules on the trunk and arms and legs along the lines of Blaschko. Herpes PCR is negative. Biopsy shows eosinophilic spongiosis. Which of the following extracutaneous findings is most likely? Is it A, aortic coarctation, B, dental anomalies, C, glaucoma, D, mental retardation, or E, seizures? The correct answer is dental anomalies for incontinentia pigmenti. Although patients with IP also have seizures and mental retardation, dental anomalies are more common. Incontinentia pigmenti is an X-linked dominant disorder. The main extracutaneous findings include dental anomalies consisting of absent or peg-shaped teeth, ophthalmologic findings, and CNS anomalies. It's recommended to have a dental evaluation by age 2 and have early and serial ophthalmologic exams. The first stage of incontinentia pigmenti is the inflammatory stage that presents in the neonatal period with vesicles. It then becomes the verrucous phase at 2 to 6 weeks of age, up to a year of age. The lesions then become hyperpigmented, and then the final stage of incontinentia pigmenti is atrophy, but often there'll be hypopigmented, faint, linear streaks that are visible. Patients could also have nail dystrophy or a scarring alopecia. Which of the following clinical findings are characteristic of a patient with ectodermal dysplasia? Is it A, macrocephaly, palmar and plantar pits, and odontogenic keratocysts? B, multiple epidermoid cysts, lipomas, osteomas? C, sparse hair, peg teeth, dystrophic nails, and decreased sweating? D, mucocutaneous lentiginous, GI polyps, and adenocarcinoma? E, ash-leaf spots, shagreen patch, or angiofibromas. The correct answer is C, for ectodermal dysplasia. There are many different types of ectodermal dysplasias, but some of the major characteristics include having sparse hair, dystrophic nails, and decreased sweating. Moving on to benign and malignant neoplasms in children. A common birthmark that we see in pediatric dermatology is a nevus sebaceous. This is most frequently located on the scalp, presents as a yellowish to pink hairless plaque that's congenital. It will become more verrucous during puberty, and there is a small risk of developing benign tumors, especially basal cell carcinoma. So for that reason, we monitor them for changes and recommend excision at some point. If these are excised during puberty, it can be done under local anesthesia, which is an advantage. Very large nevus sebaceous can rarely be associated with a syndrome called Schimmel-Penning syndrome that also has associated neurologic defects. A dermoid cyst is another type of growth that we'll see in young children. This is a congenital cyst, usually visible in the first year of life, and can be located on the head and neck, but most commonly along the lateral eyebrow. When these lesions are midline, it's important to do imaging prior to excision to exclude a tract to the CNS. And the treatment is generally going to be surgical excision due to natural history of gradual expansion and risk of pressing on the bone. Here is a table for your reference that you can pause and read on the short and long-term effects of sun exposure. How concerned should you be about melanoma in children? New nevi are very common in children, and melanoma is very uncommon in children. Less than 20-year-olds account for less than 0.5% of melanomas. However, there are certain types of melanomas that children do get. These can include congenital melanoma from maternal metastases, melanoma within giant congenital nevi, amelanotic types of melanoma, superficial spreading, which is seen in adolescents, spitzoid melanomas, acral melanomas, or melanoma in immunosuppressed patients. Here are some examples. This is an amelanotic melanoma mimicking a PG, a pyogenic granuloma, on the wrist. Another example of a melanoma presenting as a new dome-shaped, darkly pigmented papule, or an amelanotic pink nodule that developed within a giant congenital melanocytic nevus, an acral melanoma on the heel that initially mimicked a wart. Criteria to diagnose conventional melanoma are the standard ABCDEs, and I think that these hold true for most adolescents. The ABCD stands for asymmetry, borders that are irregular, multiple colors, diameter more than 5 millimeters, evolving lesions. There are additional ABCD criteria to be used with conventional ABCDE criteria, and this is because acquired nevi in children sometimes have some of the ABCDE criteria. So these additional criteria to consider for pediatrics include A for amelanotic, B for bleeding bump, C for color uniformity, because it might be the same color rather than multiple colors, D for de novo, and any diameter. Other growths that we'll see in children include a solitary mastocytoma or multiple mastocytomas that we call urticaria pigmentosa. Urticaria pigmentosa usually presents with brown macules that urticate. Sometimes there's also blistering that happens. With a solitary mastocytoma, you'll see morphology like the thigh of this baby, where there's a hive-like lesion with central blistering. A positive Darrier sign is when you scratch one of these lesions and it causes a hive. It's also important to ask about systemic symptoms, so ask about flushing and diarrhea for symptoms of systemic involvement of mastocytosis. I usually will do a CBC and tryptase as further workup for signs of systemic mastocytosis. If these tests are abnormal, then referral to hematology oncology is indicated for further workup. Evaluating and managing drug eruptions. Here's a table for you to review to summarize the characteristics of major drug-induced eruptions. An 8-year-old girl who was treated for a staph infection 3 weeks ago with trimethoprim sulfamethoxazole presents with a 4-day history of worsening generalized morbilliform eruption, facial edema, and a fever. She has generalized lymphadenopathy, and her lab show elevated eosinophils and hepatic transaminase levels that are twice the upper limit of normal. What is the likely diagnosis? Is it A, Stevens-Johnson syndrome, B, Kawasaki disease, C, Dress syndrome, D, toxic epidermal necrolysis, or E, erythema multiforme? The correct answer is Dress syndrome, which is suggested by having antibiotics treatment 3 weeks prior, and an associated morbilliform rash, facial edema, and multiple lab abnormalities. DRESS syndrome stands for drug eruption with eosinophilia and systemic symptoms. And another name for this is also drug-induced hypersensitivity syndrome. Not all patients have eosinophilia, and so sometimes we call this DIHS as well. And there are 6 criteria for a definitive diagnosis of DRESS syndrome. It's a delayed onset of a rash 2 to 8 weeks after drug initiation, most commonly caused by anticonvulsants or antibiotics. The patients are febrile and usually hospitalized. They have enlarged lymph nodes, more than 2 sites of involvement. They need to have involvement of 1 or more internal organs, which could be liver, kidneys, lungs, or the heart. They may have blood count abnormalities such as elevated lymphocytes, elevated eosinophils, and low platelets. There can also be reactivation of HHV 6, 7, EBV, or CMV. To manage DRESS syndrome, it's really important to immediately stop the offending drug. If the patient's on multiple drugs, a drug chart can be helpful to figure out the timing of the medications and the most common culprits. Topical steroids and antihistamines can help itching in mild cases. However, usually systemic steroids are indicated as our first-line therapy, usually dosed at 1 to 2 mg per kg with a gradual taper. These are often tapered over a number of weeks. If they're tapered too quickly, the rash may rebound. It's also important to monitor for late effects, as some patients may develop a hypothyroidism 3 months later, and so we usually will repeat labs several months later to monitor for these side effects. Mortality rate can be up to 10% for this condition. In terms of differential diagnosis, you'll want to distinguish DRESS syndrome from exanthematous drug eruptions without systemic symptoms, AGEP, which is acute generalized exanthematous pustulosis with multiple tiny pustules, Stevens-Johnson syndrome and toxic epidermal necrolysis, which has severe mucosal involvement and bullous lesions, and MIRM, which stands for mycoplasma-induced rash and mucositis. DRESS syndrome on the left has a morbilliform, bright red erythema involving the entire body. AGEP usually has multiple tiny pustules studded throughout the erythematous rash. Stevens-Johnson syndrome has severe mucosal involvement, blisters, and erosions. Erythema multiforme is a viral-induced eruption and a spectrum with mild to severe mucous membrane involvement. The morphology of the lesions is a typical 3-ringed target, as shown here in the photos. This is usually caused by herpes and other viruses. The lesions of erythema multiforme are fixed, so once they appear, they tend to stay in that location for about 7 days. There's often central dusky skin, there can be some vesicles or crusting, and your differential often includes urticaria multiforme, but this can be distinguished from having annular lesions with normal central skin, and these lesions also move around within 24 hours. So urticaria multiforme is a type of annular urticaria that is sometimes mistaken for erythema multiforme. Here are some photos of urticaria multiforme showing you these hives with central clearing, but they're very ring-like, so in some ways mimic erythema multiforme, but they lack the typical 3-ring targets. These also, like hives, move around within 24 hours as opposed to erythema multiforme, which is fixed. Stevens-Johnson syndrome and toxic epidermal necrolysis is a spectrum of drug-induced epidermal necrolysis. These are drug-induced, most commonly from anticonvulsants and antibiotics. Patients will have involvement of the eyes, mouth, and genitalia. They may have some atypical target lesions, but what's characteristic is the skin sloughing and skin pain. The body surface area delineates the difference between SJS versus TEN. Having more than 30% body surface area is diagnostic of toxic epidermal necrolysis. There's a lower mortality in children, but when there is mortality from TEN, it's usually due to sepsis or multi-organ failure. Treatment is with supportive care in the ICU or burn unit. At UCLA, we usually treat this with a single dose of etanercept. Other centers may use cyclosporin or IVIG. Sequelae can lead basically to scarring of both eyes and skin. MIRM stands for mycoplasma-induced rash and mucositis. These patients have mycoplasma infections that lead to atypical target lesions, and they have very severe mucosal involvement. So this rash very much mimics Stevens-Johnson syndrome, but is caused by mycoplasma and not by drugs. Patients also have ocular involvement. Pediatric dermatologists are also advocating to change this classification to RIME, which stands for reactive infectious mucosal eruption, because there are many other infections like chlamydia and adenovirus that can produce similar clinical features to MIRM. Thank you so much for your attention and good luck with your exams. If you have any questions, feel free to email me or to refer any patients to pediatric dermatology. In Care Connect, please type in dermatology, pediatric dermatology. Thank you.